This is a video of a deep interlamellar keratoplasty for severe stem cell deficiency from contact lenses and keratoconus. You see initially a trephine was used to make a 300 micron trephination into the cornea with a Hanna trephine. This can be done with any trephine. Now a 30 gauge needle is injected in the posterior corneal stroma, passed towards the pupil and just past the pupil, and then an air bubble is injected in an attempt to form Anwar's big bubble. Here you see the bubble did not extend all the way to the trephination site, so we simply go to a different region, again in the posterior stroma, and reinflate the air to complete the big bubble. A paracentesis is then made in the peripheral cornea, and air can actually be placed into the eye at this time. If the air goes peripheral, then you know you have the big bubble. If it hides centrally, then you know you don't have the big bubble and you need to reattempt. A crescent blade is then used to perform a bulk keratectomy, removing about 50 to 60% of the anterior stroma. And this can also be done before injecting the air bubble in a modified Anwar's big bubble technique, where the needle or cannula is now injected into the remaining stroma to form a big bubble. Here the stroma is now removed, and you can see the small bubble inferiorly out to the side, which tells you that there's an appropriate Descemet's membrane detachment. Helon's placed now over the stroma, and a stab will be made into the stroma, and the air immediately releases. The Helon just makes the air release slower, gives you more time to pull that sharp needle back out. Now a blunt dissector is used, and you can do 4 quadrants as Anwar describes, or as you'll see here, we're doing essentially a modified 3-quadrant area. The stroma is just gliding along the Descemet's membrane and bluntly extending the separation between the stroma and underlying Descemet's membrane. We use some blunt scissors to perform this technique. Obviously, very sharp scissors could cause a puncture of Descemet's membrane and a perforation. And you can see now the peripheral bubbles now move centrally because we've released the air completely. And now we're just simply removing the additional stroma layers, taking very care to not cause any puncture. You can see in the peripheral trephination site as well, oftentimes you can take a blunt spatula and just again separate that area as you see here to make sure there's no small adhesions that might cause perforation with the scissors cut. Again, removal of more stroma, and you can see a nice clarity of the underlying Descemet's membrane. And here's that step again showing a separation of those small stromal fibers, which can oftentimes be at the trephination zone. And it's a very easy maneuver and prevents potential perforation with this very delicate step. Now you see the Descemet's membrane endothelium has been stripped from the donor endothelium, from the donor cornea, and now we're just simply opposing the epithelium and stroma donor tissue to the recipient bed. And this is 10-0 nylon sutures, and I tend to use interrupted sutures for these procedures as it gives slightly better apposition to this layer of tissue. And here you see a slip knot being performed. Obviously any suture technique can be performed for this. I prefer the slip knot because it gives us better suture tension approximation. And so there are 4 single throws. This step actually causes the suture to be tight, and then after the first initial 2 throws we do a 3rd and a 4th throw to permanently secure the knot. And this is done essentially in 16 equidistant 10-0 nylon sutures are passed in this case. As you can see, the last suture, the 16th suture being placed now. And then we'll just show completeness of the 3rd and 4th throws on this slip knot technique. And again, you can see the bubble being left centrally, and I often leave this in place as it protects you against a double anterior chamber. It just provides extra support so fluid can't penetrate that tissue. And now you see all the